Good afternoon, everyone, and welcome to today's webinar, Interim IPAC Recommendations for the Use of Personal Protective Equipment for Care of Individuals with Confirmed or Suspected COVID-19. This webinar today is specifically targeted to an audience of those working in long-term care and retirement homes. My name is Tim Cronsberry, and I'm the Manager of Infection Prevention and Control at Public Health Ontario, and I will serve as today's moderator. So before we begin, I just wanted to go over a few housekeeping things. The Zoom chat pod has actually been disabled for this webinar just to try and limit distractions for the speakers. However, you'll still see the chat pod being used by those behind the scenes at Public Health Ontario to provide links to some of the things that are being mentioned. And if in the Q&A session, there's a particular resource that is mentioned, we'll try and put the link to that resource into the chat pod as well. If you have questions, there will be a Q&A session at the end, and you can use the Q&A pod at any time during the webinar to pose a question, understanding that your question may be answered by material that will be presented throughout, but that doesn't matter. If you have a question, feel free to use that Q&A pod, and we will try and get to your questions at the end. If at any point during the presentation you have technical issues, if you look in the chat pod, there's already a link in there to email capacitybuilding@oahpp.ca, and our Public Health Ontario staff can help try and troubleshoot that. So our speakers today, we have two speakers, Dr. Maureen Cividino, and Dr. Cividino is one of our infection prevention and control physicians at Public Health Ontario. And we also have Sandra Callery, who is a senior advisor in infection prevention and control at PHO. So with that, we'll continue on and move to the next slide. So as many of you know, Public Health Ontario, our work really is guided by the best scientific evidence. But as you'll hear and see some of the content throughout this presentation, we'll make reference to Directive 5 from the Ministry of Health. So the webinar today, the content is based on the recently released PPE technical brief from PHO. But Directive 5 really will guide you into what the Ministry of Health requires you to do in your particular setting. We're going to have several poll questions throughout the webinar, and the first one is on your screen now. Have you reviewed PHO's interim IPAC recommendations? So if you can just choose one of those, and then we will see what those results say. All right, wow, 90% of participants have reviewed that document, which is great. But for those of you who haven't had a chance to review that yet, that's okay. We're gonna hit the highlights of that today. And again, both the content of the webinar and particularly the Q&A session at the end will be useful for you, even if you haven't had a chance to review that. All right, well, without further ado, the objectives of the session today are threefold. So to describe the layers of protection when caring for those with suspected or confirmed COVID-19, to discuss the use of personal protective equipment and other IPAC measures based on an individual risk assessment, and to identify the implementation of any required changes within the care environment. So now I'm going to turn things over to Dr. Maureen Cividino to lead us off in the presentation. Dr. Cividino.
Thanks very much, Tim. So you'll all be very familiar with this picture of the coronavirus, which is really named for its crown of spikes. And with coronavirus, I think sometimes we forget that there are 4 human coronaviruses that are already used, that we have seasonal infections with. As well, of course, we have SARS-CoV-1, and the one that we're dealing with COVID is SARS-CoV-2, and then there's also MERS coronavirus. So there are a number of different coronaviruses. They're an RNA virus. They replicate. They get a little bit sloppy sometimes when they do that. So that's why there are changes, and mutations happen all the time. It's very common in many other viruses as well. There are also variants of interest. So there are those that are VOIs, and there'll be little changes that happen, and they don't end up being of any significance from a clinical perspective or a public health perspective. But what we do really focus on are the variants of concern. So you would be quite familiar with that terminology. Those that have the clinical or public health significance of affecting one or more of transmissibility or the ease of transmission or spread, the virulence or the severity of disease, also vaccine effectiveness. So if it can sort of escape, or if you can have infection despite the fact that you've been immunized, and if also impact in terms of diagnostic testing. So this is the front page of the document then that is being discussed for today. So if we look at the Omicron then, so they've gone through the letters of the Greek alphabet and trying not to have it be named specifically in terms of the location where it was first identified. And the lineage then is, this is B11529. So this was designated as a variant of concern called Omicron, which is the small, there are two O's in the Greek alphabet. The big one is Omega, but Omicron is the little one. By World Health Organization on November 26, 21. So I'm sure that most of you would think it's got to be more than a month ago since we've been dealing with Omicron. It's all we talk about. The detection was first in South Africa. They have a very robust surveillance system and looking at the whole genome sequencing. And that coincided at a time with rapid increases in COVID-19 incidence and positivity rates, and where only about a quarter of the eligible population is fully vaccinated. So compared to other VOCs, so we've certainly heard of Alpha and Delta and others, this one actually carries the highest number of novel or new mutations, the significance of which is not as yet clear. And as of December 17th, most cases are likely now to be infected with Omicron, over 90%. Next slide. So this is an updated slide, and as happens with when things change very rapidly in infectious diseases, we have to have a placeholder for this slide because it changes every day. But as you can look at, if we look at the bottom, so the x-axis there, that takes us from October 31st up till December 21st. And then along the top or the y-axis are number of cases. So this is in Ontario. And then the legend will tell us what it's representing there. So you can see by the bars that they've just increased and increased really exponentially towards the end for numbers of cases. The ones that are a light gray, we don't have any lineage specifically for those. But you can see that for the longest time, we've had Delta, which is there in red. And now gradually around early December, then you see a switch. So where it's that gold color, that's the Omicron. And where it's kind of an aqua color, that's something called an S gene target failure. So it's a specific diagnostic test that says it's most likely to be Omicron. And it's not until the whole genome sequencing is done, which usually takes up to about 7 days later, that it ends up being confirmed. But we can pretty much say that everything has been taken over at by Omicron at this point. So this does indicate then that there is increased transmissibility. So Delta was quite a bit more transmissible than Alpha. We're finding that doubling times here are between sort of 2 to 3 days, and that each person can probably infect up to 6 other people. And also there is decreased vaccine effectiveness. So again, if we remember with Delta, that if you had your 2 doses of vaccine, you were likely protected against most infection, and at least 70% protected from developing severe disease if you became infected. And now with Omicron, we need that extra layer of protection, and that's where the province has been so zoned in on getting everybody to get those 3rd shots. And that again takes us, it appears to be to the point of, again, having about 70% protection against severe disease. And we know certainly those who are the most vulnerable are those who remain completely unvaccinated. It's not exactly clear what the mechanisms are for this increased transmissibility and uncertainty if the respiratory particles contain more infectious particles that could explain the higher transmissibility. And as I mentioned about vaccine effectiveness, that for a given exposure, there is a greater likelihood of infection. Next slide, please. So the big question that we hear all the time about, is this airborne, is it not airborne? And I think it's important to step back a little bit and look at, in terms of infectious diseases, what that means. So there's a very specific meaning in terms of what we talk about airborne, as in infections that are efficiently transmitted by inhalation of aerosols that have remained suspended in the air for a long period of time, or in air currents traveling over long distances. So if we look at our typical airborne infections, they've been tuberculosis and measles and varicella or chickenpox. So those are the ones that have been highly transmissible and in the airborne mode. When we're talking about COVID, SARS-CoV-2, and is SARS-CoV-1 as well, that it's more on the opportunistic aerosol transmission. So looking at, there really needs to be the right combination of conditions for this to happen, which includes poorly ventilated spaces and a sufficient quantity of infectious virus produced. So we know, and as if we've looked at COVID over the past number of months, that often in the summer months, then things look a little bit better in terms of numbers. People are focusing then on being outdoors. In the winter, it's not so easy to do that, and you can open the window and have a certain amount of air dilution, but we really rely a lot on what the heating, ventilation, and air conditioning space is and how effective that is. Next slide, please. So I'll turn it over at this point then to Sandra.
Thank you, Dr. Savadino. So we're going to take a closer look at some of that interim guidance. So the next slide. And as you are probably very well aware, we actually had a guidance document, a technical brief, looking at the science that we have been using for a good portion of the pandemic. And in light of the shifts and changes that we're seeing with the Omicron variant, we thought it was certainly important for us to revisit our technical brief and to see, are there any changes that we should make within that document at the time? So we have a link to that technical brief, and you should take a close look at it. Some of the key findings that Dr. Cividino has just described are found in that document. And I think what's really important to know is that we always are looking at the evidence, and not just the evidence, but also the effectiveness of many of our preventative measures, including the personal protective equipment. So with all that in mind, we took a look at the document, the technical brief, and we have made some interim guidance because we're still learning a lot more about Omicron and transmission and how effective all of our layers of protection are. So in addition to all the other layers, because they're still very, very important, the interim PPE or protective equipment recommendations are provided in the document for healthcare workers who are directly caring for residents with suspect or confirmed COVID-19. So on the next slide, we talk a little bit more about that, particularly around respirators. And I think it's really important to know that actually all the evidence and the data, looking at other jurisdictions around the world and how they've described the management of their cases, transmission, outbreaks, there is actually very limited evidence to say that the N95 respirator is more effective than a good fitting medical mask when caring for residents with known or suspect COVID-19. And we have evidence of that as well within Ontario and across Canada. However, and that's the however part, is that most of that, all those studies and the close examination have been based on the other variants of concern that we've been dealing with, not as much with the Omicron variant. So based on the precautionary principle, but based on what we do know right now with Omicron and seeing its ease of transmissibility and also the vaccine effectiveness, we have described interim measures when providing direct care to residents. So we think it's prudent that people look at using a fit tested N95 respirator, gloves, gown, and eye protection when providing direct care to residents who are positive for COVID-19. I think it's really important to note that our interim guidance, our interim recommendations are from the evidence that we have been able to gather at Public Health Ontario. Tim earlier on pointed out that our role is really to provide that technical expertise and share it with yourselves, share it with the ministry. And I want to point out that the Ministry of Health's Directive 5 is the provincial baseline standard for the provision of PPE for hospitals, long-term care, and retirement homes. So they have taken our information and then have made decisions on how that should be rolled out in their Directive number 5. So let's take a closer look at some situations or scenarios and how this might play out. So the first example is actually the direct care to residents with suspect or confirmed COVID-19. So previously we said that we recommended PPE would include a good fitting medical mask. And when I use those words, what we're meaning is that it covers the nose, it goes under the chin, it doesn't gape dramatically on the sides. It has a nice fit and fits snugly around the face. The isolation gown, gloves, and eye protection are also part of that care, PPE for care with a COVID-19 positive case. In the interim, in our interim guidance, we're recommending that you use a fit tested N95 respirator along with the gown, gloves, and eye protection. From the evidence we have thus far, it would be acceptable to use PPE that includes a good fitting medical mask or a non-fit tested N95 respirator or equivalent, but it's really important that you look at your risk assessment and that activity, where you where you are in location or in close proximity to the resident who is positive and how that plays out. So it's always really important to, first of all, think of your own personal risk and where you are in the context of the resident that may be positive, what kind of level of care or interaction you're having, and your organization's protocols and what they are requiring you to wear for care in your location. And remembering that Directive 5 is still key, still important. So here's another scenario. This one's around the aerosol generating medical procedures. Typically in long-term care and retirement homes, you're looking at a CPAP or open suctioning is often another common intervention that you may be carrying on with that particular resident. So if those types of procedures are occurring with a suspect or confirmed COVID-19 case, we had previously recommended that you wear a fit tested N95 respirator because of the aerosol generation, along with your gown, gloves, and eye protection. We also recommended that you manage that particular resident in a single room with the door closed, and that you would keep the number of people in the room during the actual procedures to a minimum. So the interim recommendations in our document have not changed in our technical brief. So they're the same as previous. Here's another scenario, this time with environmental services workers. So entering the room of a resident. Previously, we had stated that they would wear a medical mask, gown, gloves, and eye protection. And now we're saying that when environmental services workers entering and cleaning the room of a resident with suspect or confirmed COVID-19, in the interim, especially if they're going to be in the room cleaning within the resident's personal environment at the bedside, doing cleaning of the resident's washroom, that sort of thing, then the fit tested N95 respirator is recommended along with the gown, gloves, and eye protection. We do, as I said, based on your own risk and what that intervention might be. If it's closer to the doorway, a very short period of time with physical distancing from the resident, then that might be when the considerations around other protection, such as a medical mask or non-fit tested N95 respirator or equivalent, could be considered. But I want to also remind you around making sure that you are meeting the requirements through Directive 5. Here's another scenario, and this time we're discussing visitors. So entering the room of a resident with suspect or confirmed COVID-19. Previously, we had recommended that they wear a medical mask, and if they arrive without a medical mask, certainly that's something that you may need to consider to have on hand for those visitors. Along with the isolation gown, gloves, and eye protection, we have recommended that they keep visitors in with someone who is actively dealing with COVID-19, so a confirmed or suspect case, that we keep those visitors to a minimum. For the interim, we're looking at, again, medical mask or non-fit tested N95 respirator, the gown, gloves, and eye protection for that visitor. We recommend, again, limiting to those who are providing essential care, and many homes are considering restriction to fully vaccinated essential visitors. Certainly that's something you have to decide within your own home and take into consideration. So we have another little polling question for you, and we'll just pull that up. And you are about to carry out continence care for a confirmed or a positive COVID-19 resident. What PPE is recommended for this task? Great, so we see that 98% of you have selected the N95 respirator along with gowns, glove, and eye protection. And yes, so what this is capturing is that certainly currently right now, we've been consumed with what protective apparel we need to wear for suspect or known cases of COVID-19. And what we also want to emphasize is that there are other care interventions that you do that may expose you as a healthcare worker to blood and other body fluids. So it's important to know that those other pieces of protective apparel are for those types of interactions as well. So in other words, make sure that you consider your routine practices with any of your interventions in addition to the additional protective apparel you may be wearing for COVID-19. So thank you for that. And I'm turning it back over now to Dr. Savadino.
Thanks very much, Sandra. So in terms of risk, it's important to look at personal risk. So we talk about a point of care risk assessment or personal risk assessment. Also, we talk about organizational risk assessment. So the leadership in the organization would make decisions around how things should work in terms of engineering controls, for example. And just a reminder, we've talked a lot about PPE, which is at the very bottom of the list. So that is the last hazard or control rather between the hazard and the worker. So when we look at the hierarchy of controls, you want to really look at the inversion of the triangle. So the PPE at the bottom, the others are also very important. So a little bit as Sandra was talking about in terms of looking at different controls, we talk about the hierarchy of controls, which really originated in industry. So elimination as an example. So if we look at infectious diseases, smallpox has been eliminated from the world. So by having that hazard removed, then people aren't going to get infected with it. We're almost there with polio, although not completely. There are still some outbreaks that happen often in the poorest of countries. Not really an equivalent for substitution, but where we really can focus in on are the engineering controls. So that's the ventilation, which would be important, barriers that can be used in terms of protection, and then administrative controls, which are our policies and procedures, and the signage putting into place for people so that they are maintaining physical distancing, for example, putting in programs such as vaccination programs, that could even be certain testing programs that would be done. And then the personal protective equipment, which of course Sandra has explained very nicely. Next slide, please. So we've all seen people be very creative in terms of how they wear their masks. And we were having just a brief chat just earlier as we were setting up for the call, and comparing the fact that it's the little wee ones who seem to wear their masks very well. They know it needs to go over their nose, under their chin, needs to their little chubby cheeks fit into it. Whereas for adults, we see in the grocery store, the pharmacy, wherever, that often, and particularly the little nose peeker, I think that's kind of the most common one. And obviously that's not going to be effective either for source control or for personal protection. Next slide, please. So talking a bit, as I did for this section, around the individual risk assessment. So that's really where you're looking at, it's sort of a triangle of interaction. So it's between the task that's about to be performed, it's the condition of the resident that you'd be looking after, and the environment that they're in. So all three of those things, and that goes back to, it's the very first thing in routine practices that you want to do a risk assessment. And then it's completed by the healthcare worker before every resident interaction or task, and looking then, what is the risk that I could have of being exposed to an infection? And it then allows the healthcare worker to select the correct PPE required to protect the worker and any other staff in their interaction with the resident or their environment. And also very important that they receive the education and training on how to effectively perform a risk assessment. Next slide. So these are risk factors that you need to take into consideration. So if we're talking about the resident, well, is the resident vaccinated or not? That may make some difference in terms of how you're interacting with them, in terms of their ability to become infected or transmit infection. The same in terms if a resident is unable to wear a mask for source control, and that could often be the case in terms of cognitive issues, for example. And then the interaction itself. So it may be very quick. So if you're just dropping in a food tray or a medication, is different than a prolonged close contact. And particularly if you would be performing a higher risk procedure that are often known as AGMPs or aerosol generating medical procedures. And these ones then definitely would be recommended that you'd have a fit tested N95 respirator for respiratory protection. Next slide, please. So this is a next poll question. So based on the hierarchy of controls, which is the most effective? Engineering controls, that's the ventilation, cleaning, and disinfection, administrative controls, or personal protective equipment. Great. And you're right, all of those things are important. And it is part of that whole triangle. Every piece counts. But those engineering controls are often the ones that are most effective, not necessarily the easiest to put into place or the least expensive, but they are in fact the most effective. So particularly ventilation, when we can have good ventilation, is really helpful. On the other hand, in infection control, personal protective equipment is key. So I'll turn it back at this point to Sandra.
Thank you, Dr. Cividino. And I think that what we've just described here are some of those layers, the layers of prevention. And certainly we've been in the pandemic long enough to know that our risk as healthcare workers not only occurs within our workplace and our care for our residents, but also can happen in the community. And in fact, it's not uncommon and for many of us to see people being very conscientious in the workplace, donning and doffing their protective apparel, getting into the rhythm of the protocols and procedures. And then when they are off shift or going home, they relax a little bit and become a little more relaxed with a lot of their measures. And that's where we need to remind ourselves that the pandemic is a bit different than a lot of other infection control outbreaks that we may deal with in the past. In other words, the community is as much of a risk place for us as well as looking at our workplace. So it's really important for healthcare workers to remember that their exposures can happen not only at the workplace, but also and very frequently and very commonly in the community, or even the other place where we often have downtime, if you will, in our break rooms. So thinking about those layers of protection. Now, the protection, it says here in the second bullet, requires multiple layers of prevention and aimed at reducing transmission. And you need to know that this is where PHO, we've spent a lot of time looking at the evidence. What have we been observing with outbreaks and transmission around the globe, and certainly in within our province, and what things are actually shown to be effective? So each of these layers in of themselves makes a difference, but they aren't going to be the panacea. One thing, including the PPE, is that's not going to actually resolve all the issues and take away all the risks. So all those public health measures, particularly vaccination, and all those other layers of preventative measures such as the physical distancing, the masking, getting tested, staying home when you're feeling unwell, are really important to prevent the transmission. So the next slide is actually the picture that we love to demonstrate the Swiss cheese model, because it just shows that each layer makes a little bit more difference in protecting you, your loved ones, and certainly the residents that you care for. So looking at hand hygiene, again, we've been talking a lot about the personal protective equipment, but it's still really important to know that our hands travel and they touch things. And although we haven't seen a lot of with fomite transmission or contact, it doesn't mean that we still can't pick up the virus on our hands and then inadvertently touch our eyes, nose, and mouth. So hand hygiene, and maybe because that's something that we've been doing even pre-pandemic, it was an easier intervention for many of us to get in the habit of doing. So hand hygiene is important. Masking still very important, as Dr. Cividino has pointed out, both as a source control and also for protection. And we wear them in different ways depending on where we are in our workplace or in the community at large. The physical distancing, we know that plays a very important role, and ventilation, staying home when sick, and the all-important immunization component. So all of these things together need to be done consistently. And right now, with the ease of transmission of Omicron, we see that there has to be consistency and really being very diligent in making sure all of these measures are carried out on a regular basis. So we know that all of this is hard to do. We've been donning and doffing protective apparel now for a couple of years. And, you know, we think we have it down pat, but just like anything, bad habits sometimes come and creep in. So this is the time to reflect on the lanyards, the cards, the pictures you have, on the steps to don and doff your protective apparel. Making sure the hand hygiene is done as equipment's being removed, so that you don't inadvertently self-contaminate or inoculate yourself with contaminated hands. Also, we realize that for many people, the use of a respirator, a 95 respirator, is something that has not been a common part of their workplace. So putting on and taking off videos on 95 respirators is provided in this link as well, just to help you remember this. And this is a time when we help each other, right? This is a time when we need to help support each other and making sure people are donning and doffing and putting on and taking off equipment appropriately. We've also added the link to the ministry's updated directive number 5 for you as well. And certainly any additional questions or concerns, there are frequently asked questions that are going to be released both through the ministry, and we will certainly be keeping tabs of that as well. And Tim is going to tell you a little bit more about how to contact us on this particular side. So I'll pass it over to Tim.
Thank you, Sandra, and thank you, Dr. Savadino. So if you do have additional questions, understanding we're going to move into the Q&A portion now, but even subsequently, there are a few different places you can go for answers to your questions. So one is actually not listed on this slide, but it's your local IPAC hub. So hopefully everyone on the call knows that there are IPAC hubs right across the province for all areas. And hopefully you're already connected in with your IPAC hub. And that's a good place for you to pose your questions. You can also send them to Public Health Ontario through IPAC at oahpp.ca. And Sandra has mentioned numerous times, as has Dr. Cividino, about Directive 5. So we can't underscore the importance of Directive 5 enough. If you have specific, more policy type questions or questions specifically about the directive, then you can send those to emergencymanagement.moh@ontario.ca, that address on the screen there. So with that, we are going to move on to the Q&A portion. And so Sandra and Dr. Savadino, the first question, and it just for everyone's interest and information, what we're going to try and do, because a lot of the questions that come in are somewhat similar, we're going to try and theme the questions. So when I pose these questions to Dr. Cividino and Sandra, you may not hear the exact wording of your question, but what we're going to try and do is ask all of them, but in a way that really encompasses the variations that we're seeing. So the first question is more so around that the use of PPE and when to doff the PPE. So when to remove the PPE. So we've talked a lot about N95 respirators. So when care has been provided, is that N95 respirator and the other piece of PPE, do they need to take that off at the door, in the hallway? Can they visit more than one resident? If you could make some comment on that, please.
Well, I'll start, and Dr. Savadino can fill in the gaps for me. Certainly, in our recommendation is around those who are suspect or confirmed COVID-19 cases. So they will be on additional precautions. And ideally, the protective apparel that you're wearing for that direct care intervention with the resident should be removed before leaving the room or at the doorway. And that configuration can vary or change from one organization to the other, one facility to the other, in terms of the design and layout. So I would strongly suggest that the actual physical location of where that apparel is both put on and taken off are clearly designated and in consultation with your local infection prevention control team, so that you can make sure that your decision is not putting anyone at harm's way, or you inadvertently could contaminate your clean supplies and your soiled supplies. I think the other part to the question that you're alluding to is really around, can I extend the use of my protective apparel? And for that, I think we need to carefully take a look at what is happening. Currently, we have been told that we do not have a scarcity of supplies. And so ideally, anytime you are caring for someone who is known or suspected or known to be positive, and you're carrying out activities where you're in close range, you may be carrying out a procedure where there's droplets or spray, this equipment is contaminated and should be removed before you move on to for care for another resident. So I think that's really important to consider. We do have some other guidance around extended use if we do come into that particular circumstance or situation down the road. But ideally, we're talking about those using the N95 fit tested respirator for those who are known or suspect to have COVID-19.
And maybe I can bring Dr. Cividino into this part of the conversation as well. Would there be, so Sandra has just described those direct care activities, and Dr. Cividino, in one of your slides, you talked about the conditions where you're in a poorly ventilated space, you're in longer contact. What about a scenario where someone is perhaps just delivering a food tray? Would they, in that circumstance, would they have to change their PPE at the door if they were doing an activity that's perhaps less prolonged than direct care?
Right, thanks very much, Tim. And that again brings us right back to that point of care risk assessment. and looking at the environment that you're in. So if you're doing something which is essentially a clean activity, you're dropping off a food tray, you're bringing in medications, you're having a short interaction. In those situations when you're not really anticipating other either prolonged exposures or exposures to patients' droplets from the activity you're doing, such as suctioning, for example, then those are situations where you could have the N95 and keep it on as you're going in between patient care. But still always noting that if you feel that it may have become contaminated or that it's damp or soiled in any way, that it would need to be immediately changed.
All right, and pardon the pun, but I'm going to layer another question on top of that, and ask. So there's been a couple of questions in the Q&A pod about the layering of PPE. So in that situation where you have an N95 respirator on, why can't people just put a medical mask or another mask on top of that to kind of save the contamination of the N95?
Well, I certainly appreciate the question and understand the thought about looking at environmental waste, et cetera, and the additional cost for N95s over a mask, for example. But at the end of the day, I think we have to also look at how PPE has been designed, and it needs to be worn in the way that it's been designed. So with an N95 respirator, it's fit tested and it needs to be seal checked. And that should be done anytime that you're either taking it off and then putting back on. It gets really complicated when you start adding additional pieces of PPE. It gets much more likely that you're actually going to contaminate. And we know that most of the contamination happens during doffing. So in doing that, you have multiple opportunities for contamination. And in addition to that, we don't want to increase unnecessarily the breathing resistance for the healthcare worker. And by adding a surgical mask on top of an N95, that's going to be more fatiguing.
Great, thank you for that. Another question that that is being asked both in the webinar, but we've actually had some questions come in through our email as well in the last few days. So if we can talk a little bit about the differences between a confirmed COVID-19 and a suspect or probable.
Sure, I can start with that one. So you start with, first of all, when you're seeing a patient, you're making a clinical assessment. So this is somebody who hasn't already been diagnosed, for example. So in the suspect, you're thinking, gosh, this person's coming in with symptoms that are suggestive of COVID. They have a fever, they have a cough, or they may even have some of the other symptoms that are loss of taste or smell, but little flags that will say, this one looks like I think this one's going to be COVID. Or you have the history from them that they have been exposed to someone who's had COVID. So they, again, are going to be more likely to be having COVID if they're presenting with those symptoms. So the whole idea is that as soon as that flag goes up, you make that decision in your point of care risk assessment in terms of what you need to do in terms of isolating the patient and what you need to do then in terms of your own PPE that you would use. So that's the suspect side of it. And then it confirmed is when you follow through, and part of that is then you do a test. So a PCR test is the most sensitive specific case for determining what a result is for COVID-19. And there are, unlike the point of care testing, which is typically rapid antigen testing, you can get some information that may come back and confirm what you think is positive, but you still need to get that additional confirmation through the laboratory. And fortunately in Ontario, we have pretty good turnaround time, but of course right now with Omicron, that gets a little bit delayed. So it may be 24, 48, 72 hours before you actually get that result. But when you have that result, that's the confirmation in terms of COVID-19.
And I would just add, I totally agree with everything Dr. Savadino has said. And in addition, I think people need to remember that if you are taking the initiative to place someone on additional precautions, then part of that additional precautions for COVID-19 is to consider the fit tested respirator, gowns, gloves, and as well, and eye protection if you're carrying out activities with that particular resident. So it's really just a matter of being consistent with what now is considered your known or suspect cases. We're not asking you to change your approach in terms of identification. And Dr. Cividino has given lovely examples of how that process typically works out. So thank you.
Well, and this flows nicely into the next question, because we know in the, not just in the long-term care and retirement home setting, but especially in the setting, the use of rapid antigen tests. So this next question is about a PPE that the staff member who is conducting those rapid antigen tests on visitors or caregivers that are coming in. What PPE should they be wearing? Do they need an N95 respirator?
Go ahead, Sandra. You go.
I was just going to say that initially so certainly we have not recommended that they need to wear N95 respirators in carrying out this procedure, because it's sort of it's part of the random testing. People should have also self-disclosed if they're exhibiting any signs and symptoms and exposure. So all those screening questions should have been asked as well at this point in time. So which is a little different than someone coming forward and saying, I have symptoms, or I feel I'm exposed, or I think I may be coming down with COVID-19, and then carrying out the testing under that circumstance, which is a bit different. But Dr. Savadino, you might want to add.
You raise a really good point, Sandra. It's important not to confuse when we're talking about surveillance. So in that sense, so anybody who's symptomatic, we don't want them there anyway. And then if they are being tested, so for long-term care, as an example, all the staff are being tested twice weekly. And in terms of looking at if to try to pick up something if there is an early case, but really the definitive case is going to be the PCR. So if somebody is symptomatic, then that would be a concern in terms of choosing the PPE. But if they're coming through the door, they really shouldn't be screening positive for symptoms in the first place. And certainly in that situation, a surgical mask would be definitely sufficient.
All right, lots of great questions coming in. So again, particularly at this time of year, and I know Omicron is maybe throwing a wrench into to some of the holiday plans, but long-term care and retirement home settings tend to see more movement of residents in and out during the day to family events. So again, I know that our CMOH, the recommendation is to try and reduce that as much as possible. But can you comment on the use of masks in particular in those other settings? And I know we're talking about long-term care and retirement home setting, but I think it's a relevant question because of this movement. So what's the guidance for other community settings?
Maybe I'll start, Sandra. And it's interesting because that's been changing a little bit over time. Even Public Health Agency of Canada is really focusing on the importance of a good quality mask. So it's not a mask is a mask is a mask. Or face coverings, for example. So a number of studies have been done to show that indeed, if you want from good source control, you really do need to have a 3-layer mask. And either 2 layers with a filter or 3 layers. And again, it needs to be well fitted, and it also needs to be worn correctly, as we've said, in terms of over nose and under chin. But I would say that it would be important in that environment, particularly with vulnerable folks that we have in long-term care and retirement homes, for them to really consider in the home environment that they may choose to wear a medical mask when they're exposed to their loved one.
And so I totally agree. And in addition, I think it's also important for people, if wherever possible, they do try as following the guidance from our Chief Medical Officer of Health around the size of the gathering. If they're going out for a family gathering, that interaction, who can continue to wear a mask during that interaction, and that those that they are attending, wherever possible, if the resident can confirm, and the home can confirm that the resident is going into a home where people are immunized. So it's all of those elements together, all those layers that we talked about, wherever possible, if you can make sure that as many of them are in place, including, you know, that they're in a well-ventilated space and all those other things as much as possible. So it's really a matter of reviewing that, I believe, with both the resident and the family as they head out for the day.
And just to add on to that as well, in terms of a helpful resource, we may be able to put a link in the chat. There's kind of two pieces. So one was a more technical report that PHO published on our website last week about masking in the community. Another actually isn't on our website yet, but almost. It'll likely be up by the end of the day tomorrow, and it's a fact sheet on community masking. So again, I know we're talking about long-term care and retirement home here, but Sandra, as you and Dr. Savadino have said, I think the discussion with the family or others who may be taking a long-term care home resident out of the home to another setting, that might be a useful resource. Now a question about outbreaks. So again, we don't want to be in an outbreak situation, but sometimes we do have those situations. So if a particular unit in a long-term care home is in outbreak, so there may only be 1 or 2 resident cases, let's say, on that unit, but the whole unit is the outbreak unit. Can we talk a little bit about PPE use, but particularly N95 respirators, because there's that staff interaction in that unit with both those who are positive and those who are not?
I'll begin that response. So in an outbreak situation, and it really depends on where you are in terms of the spectrum of the outbreak. So if you're at the beginning of an outbreak and you've just identified 2 cases, you're still trying to determine the source or possible additional cases. That is actually a time when wearing the N95 respirator while you're working and interacting throughout the unit may be prudent. As you start to gather information and determine where the cases are. And there could be cases also amongst the staff at that point. So, but at the other end of the spectrum, when your outbreak is resolving and you may only have 1 or 2 cases left in the unit that are certainly on additional precautions in their rooms, it may be that you can now, again, target that additional PPE, the N95 fit tested respirator for those 2 cases, and then return to the medical mask, a good fit testing, a good fit check with your medical mask, I should say, and making sure that, and wearing that throughout the rest of the unit, because things are more in a controlled situation. But for both those scenarios or situations, this should be done in collaboration, in consultation with your local public health unit, because a declaration of an outbreak is something where your health unit is actively involved in the management of that particular outbreak.
Great, thank you. So I'm just doing a time check here. We only have 6 minutes left, and unfortunately, we're not going to be able to get to all the questions because there are a lot of them. But one that may be a quick answer regarding visitors. So those who are coming into the long-term care and retirement home setting, who understandably will be bringing their own masks. So they may be coming with what appears to be an N95 respirator. Some may be wearing a medical mask or other various types of masks. So the screener at the entrance to the long-term care and retirement homes, should they be asking the visitor to change their mask and use one that is provided, or are there variations on that advice, depending on if they're showing up with just a scarf?
Maybe I'll start with that. And that's a really good example. So I think the face covering, the scarf is not going to cut it. I don't think in that situation that cloth masks should really cut it either. So I do think it would be a good practice for any of the homes to offer a medical mask to any of the visitors who are coming in. There could be some wiggle room or discussion, depending on what works for the home around a visitor that would come in with their own N95, for example. So it probably wouldn't be fit tested. It would probably be just something that they would be wearing, like a KN95 as an example. That is, it can be a respirator, but is often worn as just a good fitting mask. And there could be discretion, but I think it depends on the home. And I know we try to keep things simple. So I think if the home were to make the decision that, no, you come in and this is your medical mask that you're going to wear while you're here for the visit, I think that would be a perfectly reasonable suggestion as well.
I don't think I have really anything to add. I think that that's, you know, it is all about making sure that if we have an expectation for our staff and our residents and what we have for them to wear, that we would also ensure that we have essential visitors wearing the same type of medical mask that we would expect for the residents.
All right, thanks. And again, I'll try and squeeze in a couple more questions here. There's a question about the clarification of when eye protection is needed, but I think in the slides presented in the different scenarios, there was a clear indication of when eye protection is needed. Don't know if either Dr. Savadino or you, Sandra, have any additional comment on that.
Mm-hmm. Well, I'll start. I think the eye protection, of course, is actually when, especially if you're in close proximity, so that you want to protect the eyes, these mucous membranes from droplets and spray that they may be exposed to. So definitely when you're in that close, intimate contact, and if you are dealing with a resident where they may play around with their mask or pull down their mask, or if they have some confusion, those are the times when the eye protection will be most important for the healthcare worker. Another example might be that I'm assisting with feeding a resident, and therefore they cannot be masked, but I'm in very close proximity. So my mask as well as my eye protection becomes very important.
Sorry, Tim, I was just going to
go ahead. Yep.
And there can be consideration during outbreak. So if you have a unit in outbreak, that's often another situation, just talking about those layers of protection where you may have staff wearing eye protection as well.
All right, and I don't think I can get into another question because I'm going to get in trouble here if we run over time. So the last one that I won't pose as a question, but just a further clarification that Directive 5 is an important document for you to study as well, and the content presented today is based on our interim technical brief. But you really need to follow Directive 5. So with that, we'll wrap up today's session. The slides will be posted on our website, and actually a recording of this webinar will be posted on our website too. It's going to take a few days for us to do that, but if you have colleagues who weren't able to attend this, or if you want to watch it again, there will be a recording on the website. And the FAQ that was mentioned earlier, a version of that should be on our website, hopefully by end of day tomorrow. And that's going to be a dynamic resource as well. The questions that have been asked in the webinar today and in the other webinars we've held, we'll seek to add those to, or some of those to the FAQ. So hopefully we'll continue to improve that resource as well. So at the conclusion of this, you'll also be receiving an email asking or inviting you to complete a survey. If you could just take a couple of minutes to complete that survey, it really will help us to improve our webinars and really give you what you need and what you want to help make your jobs easier. And the last thing I'll say is just another thank you. I know that everyone on the call today has been working incredibly hard over the last couple of years, before that as well, but the pandemic has been a very stressful thing for all of us to go through. And we all, in all aspects of healthcare, really appreciate everything that you're doing. And we hope that you keep yourself, your family, and your residents safe. So with that, happy holidays and enjoy the rest of the day. Thank you.